Are you confused about taking the pill for menopause? Are you wondering why no one talks about pellets? And have you ever thought that if HRT is so breast protective, why do we need mammograms anymore? Then this episode is for you. These are questions that I got on my YouTube channel. It's a great place to learn more, to see our guests in person, and also to ask questions. So if you want me to answer questions that need a little bit more detail, because sometimes I can answer questions pretty quickly there, but there's nuance to all of these things. So I want to make sure that I cover them really well for you. So thank you for submitting those questions. We're going to cover them today, and we won't spend too much time on it. It'll be a quick episode. It's from MSBA09994. But she asks, what about taking oral contraceptives at 50 and a lot of joint pain, mouth burn, some nights if hot flashes, still have my period, never taken any oral contraceptives. What do you think? I'm just afraid that I am not going to notice when menopause will come. Please, I need your support. Any similar stories? Always similar stories. Like, you're never alone. So first of all, take a breath. And you'll know now that joint pain, burning mouth, hot flashes at night, and still bleeding, having cycles and periods at age 50 is perimenopause. This is nothing out of the ordinary. You're not imagining it for sure, and you are for sure not alone. Like, if you were in our biohacking menopause membership group, you would see that so many are just like you. So the thing is about the pill. I just did a great episode with Dr. Carrie Jones, asking her all the things that we need to know about birth control and menopause and our symptoms and all that. So it can be an option for some women in perimenopause. And a lot of doctors may like to prescribe it just because they're comfortable prescribing it. They know how to do it. They're maybe less familiar with menopause hormone therapy. And if you're still cycling and you don't want to get pregnant, then it can help with smooth out the symptoms and the cycles as well. But they're not the same as menopause hormone therapy, and they have their own risks. And there's the risk of a blood clot, which matters more as we get older. When you're younger, doctors tend to brush off that risk, or the breast cancer risk when you're taking the pill, like, you're young and it's okay. But when we get older, it's a little more concerning. So you need to have that discussion. And they also use the synthetic estradiol and progestins in the birth control, which is a synthetic progesterone, and they're at higher doses than a menopause hormone therapy. So it's totally different than, say, body identical hormone therapy that's a cream, a gel, a patch, or something like that. So you need to learn a bit more about it and see if this really is the right fit for you, and understand what is the difference between birth control and menopause therapy. And you're right, totally right about not knowing when are you going to hit menopause. That pill, it masks your natural cycle. So you really can't tell when you've crossed into menopause and when you're in it. And the same thing is I started at 50, I started menopause hormone therapy. I still had totally regular cycles, and I decided to take it because my Dutch test, which is a dried urine test, showed that I actually had very low hormones. And I wasn't quite having symptoms, but I just wanted the transition to be smooth. I didn't want to be caught off guard or fall off a cliff. So I started at 50. I have no idea when I cross into menopause. And that's also because I'm cycling my hormones. The progesterone, I bring it in from days 14 to 28, more or less. Although I'm now changing that because I am increasing my estrogen dosage, because I feel that if I need to hit certain levels in order to not have those night awakenings or feeling hot at night, kicking off the sheets, even though I'm not in a sweat, or I don't call it night sweat and all that, it's disruptive, which I don't like. And as I increase my estrogen, I'm going to increase my progesterone, and I'm going to be adding it in now every single day, as opposed to cycling it in and out. I'm 56 now, so I think it's about time. And that's just what I do. Now, what do? You need to talk to your own doctor about that. That's the discussion you have. But you're still bleeding. You do have symptoms that are classic menopause symptoms. And this is really why it's important to talk to a menopause literate doctor or provider of some kind who can prescribe hormones to you if that's what you want, or in a menopause hormone therapy, not just, take the pill and be done with it. So that way you can really weigh the pill versus the HRT or MHT, menopause hormone therapy, for you specifically. And there's really no right or wrong answer. It just depends on your health history, what your preferences are. And I would say to definitely look into the transdermal options, like a patch, a cream, a gel, a spray, things that you put on your skin rather than taking it orally. And that's for the estrogen. The progesterone, you can take a bioidentical oral progesterone. Many providers give that if you need it. And there's creams as well. Maybe that's an option for you too. Now, just also to keep in mind that menopause hormone therapy isn't birth control. It's not going to give you contraception. So you can get pregnant. And if you need to not get pregnant, then you really have to see what other options there are. If you're going to take hormone therapy, you may need to start using condoms or have other birth control on hand. Okay, the next question is from Jill Cherny 8073. She asks, why don't any of the podcasts bring up the pellets? When y'all discuss the different methods of delivery of HRT, I never hear the pellets brought up. I'm seeing a provider that mainly uses them, but does allow other delivery methods. Like I'm on patches, creams, but pellets seems easier all around. Just wondered why this is. Are they not what they're made out to be? So this is a really great question. Pellets don't come up a whole lot because the major menopause societies around the world and hormone societies, they don't endorse them as a preferred method. And the position statements that they're giving out, they say that they can give these supraphysiological levels, like very high levels in the body. And there's just not enough evidence for that, for using them as a preferred or the first line of treatment when you have other options that they feel safer with. So the bigger issues really are that is the dosing. You can't really dial back. Once these pellets are inserted in your skin, you can't really take them out, or you can, but it's really not easy. And it's quite costly as well. So if you have a bad reaction, which can happen, you're stuck waiting 3 to 6 months for them to just gradually wear off. But if you have a patch or a cream, then you can, if you don't feel well, you stop it. The next day you'll be fine because they come out of the body so quickly. This is why we need to use hormones every single day practically, because it just gets out of the system very quickly. So yeah, it's one of those things that if you react quickly, great. I mean, react positively, that's great. But if you don't, you're really stuck. And there was something else I wanted to say about this. Yeah, okay. Pellets are, how do I put this? If you are just starting just starting hormone therapy and you're trying to figure out your dosage, how much estrogen, how much progesterone, how much testosterone, then you can titrate up and down until you find the right formula. And then once you're feeling good, then I would say if you want to explore pellets, then go check them out. I think you've kind of road tested that your body can feel good at a certain level. And then those pellets can be compounded to what you are pretty sure you'll be good on. No guarantees. Again, you may be stuck with something that's not working for you. And a lot of people poo-poo people who provide pellets because they're often in these private cash pay clinics, not covered by insurance. And then there's this conflict of interest. And is the doctor really just want to make some money and doesn't really care, or do they really believe in it? It's really kind of hard to tell. And it doesn't mean really that pellets are wrong. It's just understanding the context and having the trust as well. And the other thing is that the pellets, they don't have the same standardization or the regulation of an FDA-approved pharmaceutical hormone product. So for many clinicians, pellets really are just not the first choice when they have other options that they believe are safer and more adjustable, and they can titrate up and down. It's just more flexibility with that. And that's why people are not really into it. And there are studies that show that pellets, especially the testosterone, there are people who very often, I have many women in our community, or not many, I have some women in our community who have tried the testosterone pellets and loved it. They were amazing. And it's usually good for a while, but then it seems to backfire and it doesn't work as well anymore. And then they just eventually get off of them. But there is a podcast I still need to record because I heard it from Karen Martel. She has this podcast called The Hormone Solution, and she did a really interesting episode on a doctor who's using super physiological dosages, like very high dosages of testosterone to treat cancer patients. I was fascinated and thought, oh my gosh, of course there's not a lot of studies there, but it's something to look into. And I know that there are some people in our community who are post breast cancer who decided that estrogen is not going to be for them and progesterone maybe, but they turn to testosterone to help alleviate some of their symptoms. So that's another option, but it's just rabbit holes to go down. But yeah, some of the studies that are done on testosterone pellets show that for women, the levels are very high, substantially high. And again, that's maybe why they're feeling so great. But again, you have to really work with your own practitioner. So in this case, your practitioner is offering other things, which I think is a good sign. If the practitioner is only offering pellets and thinks this is the only thing for you, then I would definitely run the other way. And again, it's not to say that pellets are bad or they don't work. It just means that you may have a conflict of interest if there's only one option. But if your doctor's offering several choices and eventually the pellets come up, just understand that the evidence is a little thin there. Monitoring is trickier. And if there are side effects, then you can't stop the treatment the same day like you could with a patch or a gel. Does that make sense? I hope it does. I never like to demonize anything. So I try to understand the pros and the cons and then leave it up to you to decide what's good for you. I personally haven't tried pellets. I don't think I need to. I think I'm pretty good where I'm at. Okay. The last question is from Kutamo73. And she says, a very interesting conversation. I have a question. If HRT protects against breast cancer, isn't it unnecessary to have a mammography every year? How often should it be done? Now, this is why I do not like when people say, and I correct myself if I do say it, that HRT is protective, because it gives this false sense of security that you don't need to do anything else, that you don't need to get a mammogram because you're not going to get breast cancer. That's absolutely false. So please, you need some kind of breast screening no matter what, HRT or no HRT. It is not protective in that sense. It just means that you may have a lower risk of certain diseases of aging. And again, it's a case-by-case thing. So I'm really glad you asked this question. And it explains why I tried not to use that word protective. So in the Women's Health Initiative, this is one of the largest studies. I think it is the largest study ever done on women and hormones and menopause. And it was stopped in 2002. And what they did find was that the women on the estrogen-only hormone replacement therapy were about 20% less likely to get diagnosed with breast cancer. But that was the estrogen alone arm, because they had different arms of women taking estrogen, others taking combined estrogen progesterone, and then the control group. So the women who were just using the estrogen, they didn't have a uterus. Okay, because if you are on estrogen, you need to be taking a progestogen, some kind of preferably progesterone. So the women were also in that study using a synthetic form of estrogen called conjugated equine estrogen. It's not as widely prescribed anymore, though it still does, but just keep in mind this sort of newer modern hormones, bioidenticals or compounded or body identical, whatever you want to call it, were not used in this study. So when we're quoting these studies, we have to keep in mind too, what were the things they were using, and as well, the age of the people. I don't know how old this person who's asking the question is, but the average age was a woman about 62, and they weren't in very good metabolic health. So there were a lot of loopholes and problems with that study, but we still refer to it for certain things. So anyways, what was also interesting about that study is this benefit of the reduced breast cancer risk was, or like less, I wouldn't say that, they were 20% less likely to be diagnosed with cancer. Okay, so there's a difference between a diagnosis and then dying of it. So there was a follow-up analysis, and then they found that there was less mortality, lower breast cancer mortality, meaning the women died of breast cancer less in that estrogen-only group. And it was about 40% in some reports. This is why people go, oh, it's protective. It's not protective. It's just maybe reduce your risk. Okay. And it certainly means that we need to do a lot of other things, because the risk of your increased risk of breast cancer is so much higher by drinking alcohol, but nobody seems to be questioning that. So we got to put things into context. And then another arm of this study in the Women's Health Initiative was this estrogen plus the synthetic progestin, MPA, or medroxyprogesterone acetate. And this is what we call the synthetic progesterone or synthetic progestin. And this was for women who had a uterus, because estrogen can increase the uterine lining, which that increases the risk of uterine cancer. So we need to take progesterone or a synthetic progestin to thin out the lining and lower that risk. Okay, so that's why they were taking the estrogen plus the MPA. And they found out that those women had a breast cancer incidence that went up by about 25 to 28%. And this is the same sort of group of people. And so everybody's blaming estrogen for some reason, when in fact in that study, it was the progestins, those fake progesterones, that were the culprit. Yeah, just trying to put things into context. So the estrogen alone, this is why people say it's protective, but it doesn't immune you to any kind of breast cancer. There's no guarantees. I wish I could give you a guarantee, and this seems to be the problem with HRT. People want guarantees that they won't get breast cancer or uterine cancer or ovarian cancer or anything like that. We just don't know. And it depends on the formula, it depends on what you're taking and the dosage, so many things, and your history. This is why it's really important to get consulted by a professional. This is why you don't do this stuff alone. And when it comes to frequency, you asked how often do you get a mammogram? Well, generally, the general guidelines are you get it every other year from age 40 to 74, depending on the country that you're at. In Spain, for example, where I spend some time, they do it at 50. And some countries do it earlier. It depends where you're at. There's some doctors that say do it every year. Again, it depends on your situation and where you're at. When my mother died of breast cancer, I was only 23 and I was told to get mammograms every year. So that's what I was doing until I was like, I think it's a little too much. Then I met a doctor who said do it every other year. And so again, it depends on where you're at, what the doctor thinks is best for you. There's so much debate around this. There are people who don't like mammograms, who say they will never get one. Again, hopefully they're doing other things if they're not doing that. It's a very personal choice. And there's only a right answer that's for you. Again, look at your personal risk, your family history, your breast density as well. Dense breasts are harder to read on a mammogram. If you don't know you have dense breasts, usually you need to get a mammogram to tell you that you have dense breasts or not. And that's your conversation that you have to have with your own doctor. And so then the question is, I have dense breasts. So I'm like, well, wait, if I have a cancer nodule, it's going to be like a snowflake in a snowstorm. It's not going to show up as easily. And so that's where you have to talk to your doctor about maybe getting an ultrasound or an MRI on top of the mammogram, or every other year, or it depends. Everybody's different. So I kind of do it all. That's just where I'm at, because there are pros and cons to all of these screenings. So I have a great episode on breast cancer screenings, because I've interviewed people who are pro mammogram. I've had people who are anti mammogram, and the conversation is so confusing. But I'm going to put in the episode where I brought it all together with Dr. Elizabeth Yurth from Boulder Longevity Institute, because she's so grounded and so reasonable. She's not selling anything. She's just looking at the science, the research, and she's a longevity doctor. I really trust her. And she brought so much sense to the conversation. I'll put that link to that episode, because it will help you decide what is the right route for you. So hopefully that's helpful. Not only if you're following the YouTube channel, please subscribe. Hit that subscribe button while you're there. It really helps me grow as a channel, as well as getting you informed of new episodes that are coming out every week, twice a week. And did you know that we have a YouTube Clips channel? This is a place where you may just have 10 minutes, 20 minutes. You don't have a whole hour to dedicate to learning more about menopause. And it's the bite-sized information that you need to know, or some highlights from some of our guests. So please go to the YouTube Clips channel, and I've got links to both of them in the show notes. I also have a link to our newsletter. If you haven't signed up yet, please sign up. I've got loads of other information there. And I always cover some menopause new studies, or some new products I'm taking, or what's going on in my life. And it's short, it's bullet point, not too much is there. You can scroll through it pretty quickly. And the last thing is to let you know that we do have a private membership. If you want me to answer these kind of questions more in depth, it'd be more targeted, because the answers I'm giving here are obviously quite general. I don't know the people who ask the questions. I don't know their health history. I don't know their preferences. I don't know where they're living. I don't know what they have access to. But if you want me to guide you a little bit more, not only with myself, but also our guest experts, because if you like our guests, they come on every week after week, for live Q&As, and we're still a small group. Only like 5 people show up at a time. So you will get your questions answered for sure. So I have a link to Biohacking Menopause. This is the group coaching program that we have, in the show notes. Thank you so much for being here. I wouldn't be here without you. So thank you for coming out to the end. And if you have more questions, please drop them onto YouTube. That's where I go and I collect many of these questions. If you found this episode useful for yourself, maybe you know somebody else who also would benefit from it, please share the episode. So thank you so much. Have a good day, good night, good morning, wherever you're at, and I will see you next time.